executive leadership in academic medicine through Drexel University, and also completed a Master's of Science in Health Administration. She has transitioned into the role of Senior Professor for Child Mental Health Policy. She has also served as a President of Wisdom from 2003 to 2006. She has served on 2 statewide initiatives for systems of care reform in child mental health and early intervention programs in Virginia, and champions the involvement of families in the development of child mental health policy. She served as the co-chair on the National Task Force for School Violence from 2014 to 2016. She was appointed by Governor Warner to the State Board of Social Services for an 8-year term in June 2005. She was appointed by Governor Tim Kaine as the mental health expert to the Blue Ribbon panel that investigated the Virginia Tech massacre. In 2018, she was appointed by Governor to the Governor's Working Group on Trauma-Informed Care to Children in Commonwealth. She's received several awards and recognition, too many to count, during her really remarkable career. In the recent years, she has focused efforts on prevention in child mental health, within which she is focusing her efforts in developing an attachment clinic, supporting work that improves education in early childhood and infancy, reduction of stigma, adequate workforce, and violence prevention efforts. She has edited 2 books on mental health policy and prevention in children's mental health. Her 3rd book is on children and social justice, which was published in December of 2020. Her work on violence prevention was really instrumental when we started conceptualizing the Institute of Living Homicide and Violence Assessment tool, I Have It, that is being used on our inpatient units. Today, she will talk about gun violence, a public health emergency in the United States, and we'll talk about the impact on the mental health, how to frame it from a public health perspective, and how to impact policy change at state and federal level. And what a timely grand round given recent unfortunate incidents. I will now hand it over to Dr. Sood for her presentation. Welcome, Dr. Sood.
Thank you so much, Salma. And I know Mirella Loftus and Lisa Namarao and Kevin Young. So we've had a nice collaboration in the past, and I'm so glad to be speaking to all of you. I wish I had been there in person, but obviously not. So this is your instructions for your getting your CME credit. I guess it'll be displayed later too. So I'm going to move on and talk to you about this topic, which I guess is really a public health emergency for us, certainly with the 2 incidents which have occurred in Colorado and Atlanta in the past week. It illustrates and really brings into bold relief the types of problems that we experience, not because of the baseline issues with violence, but the way it's committed, and particularly the role of firearms. And so this is by disclosure. And what got me interested in this, as Salma points out, I have been involved with the Virginia Tech massacre in 2007, but that just got me sort of a tad bit interested. But subliminally, I think what I was experiencing as a clinician was the angst and distress that I would see with these young kids that I was treating, and almost on a weekly basis, hearing the trauma which they were experiencing in their lives. Most of it related to homicides that they had witnessed or they had been a part of, or they had watched their young cousins or going to funerals. And this would occur almost on a weekly basis. And rather than becoming desensitized, I really became very interested in knowing this and thinking as a child and adolescent psychiatry, what are the elements within this that can become an issue that physicians could get interested in, as well as approach it from a public health perspective, from the prevention aspect. What could we do to prevent many of these things from happening? As you all know, it is a very polarizing topic and really leads people on 2 sides of the aisle. And the purpose of this conversation is really not to kind of be judgmental about who owns guns and who doesn't, and not the Second Amendment, but really coming up with a framework which will allow us as healthcare providers to get away from that topic, but to really talk about how can we promote safety in owning guns. And I think that's a good way to sort of look at it. So this is sort of a little bit of my background, certainly not my whole world, but I do use to inform some of the works that I do in community engaged fashion. So we will go over very briefly the epidemiology of gun violence. We will talk about very briefly the impact on the mental health of kids, because we all know that it can't be anything good. Framing the gun violence more as a public health issue, just as, say, smoking has about 2 decades ago and really led to a lot of changes. And how can we impact policy change at a state and federal level to prevent and reduce gun violence? And remember, I come from Virginia, which is a southern state and was primarily Republican for a long time, where these things could never be discussed. And I can tell you from my own experience, we have come a long ways, baby. And in fact, in this General Assembly session, many bills have been passed already, which speak to sort of really the focus has been on reducing the presence of firearms in certain locales, as well as we are now the 20th state to go into the ARPO laws. So I feel very good about being part of this discussion. So no discussion without really looking at how we have arrived at this point. So you all probably remember Surgeon General Everett Koop. He was on the face of, and I'm dating myself, but he was a big presence in my life, at least in the 80s and 90s, where he focused on really looking at injury prevention, be it motor vehicular accidents, the effect of smoking on the lungs, etc. And gun violence was another one of his issues that he focused on. The CDC developed the branch on violence prevention and injury prevention, and under that auspices began to look at gun violence and published a seminal study, which was published in the New England Journal of Medicine, which spoke about sort of the notion of how having and owning a firearm increases the rate of either suicide or homicide within the home, which led the NRA to really get its hands up, and it basically proceeded to discredit the CDC, asking for CDC funding to be reduced by $2.6 million, and also led to a ban under the Dickey Amendment, which stopped the CDC from using any of its funds for research into gun violence. Side by side, the Doc versus Glocks in the Florida area, where a pediatrician asked, do you own a firearm, led to a flurry of activity with the NRA getting up and saying physicians do not have any right to be asking their patients about guns presence in the home, and led to a whole bunch of laws, the Florida Firearm Owners Privacy Act, etc., which has been fought at many levels by our profession. Open carry laws. So there's a political piece to it, and there's a public health piece to it. Often the NRA telling physicians, stay in your lane. And I think the purpose of this conversation is that we are in our lane when we talk about firearm violence as causing a public health hazard. When President Obama came into power, I should say, he appointed Vivek Murthy and put in a number of suggestions for firearm reform. And however, these were never funded. And then we kind of look back and take a look at Senator Dickey's ideas and Rosenberg, who was then the CDC chief. And both of them have aligned together and feel that that was an overreach, and this law, this amendment needs to be changed, and so on and so forth. So that's where we kind of stand. And as you know, it is a very bipartisan issue that background checks should be, but you're seeing the kind of problems it is facing at a federal level, even at this point in time. So having given you this history, what do we know about gun violence? When we look at the data, 40,000 gun deaths occurred in 2018 and more than 71,000 injuries. So these are not figures that can be sneezed at, and predominantly much of it were suicide, largely, and homicides, a smaller number. So suicide is one of the big problems, and I know that you guys had a grand rounds on suicide early this year, so I know that you know that data very well and how firearms figure in it. So when we look at the prevalence of gun ownership in the United States, we do find that slightly less than 50% of homes have a gun in the home. So we are looking at children. I'm particularly interested in that aspect, and that either they own a gun or they are living in a home with someone who has a gun. When you look at gun owners, it's not simply having one gun, majority of them have more than one gun. And within this sliver of the population, 37 have 2 to 4 guns, 37%, and 29% own more than 5 guns. And essentially, what is kind of spoken of as a reason for owning the gun is for self-protection, for hunting, for sports, and for having it as a collector's piece. So these are the reasons that gun owners give as a reason. If you look at the prevalence of gun ownership geographically, you find, and I think this is fairly intuitive, the West, Midwest, and South have a high preponderance of the gun owners, whereas the Northeast, which is where you guys are, 27% of the households are gun owners. And if you look at the type of gun that's geographically, it's kind of nice to see how that kind of passes out in how it translates into the mortality. So look at the rural Northwest, and so you have high suicide and low homicides. Wonder if it sort of connects to depression. Southeast, there's a high suicide and high homicide rate, and the Northeast is the lowest amount of suicide and homicide, which may be reflective of the way the households are. So this, again, makes an argument for the presence of guns and how they connect to both suicide and homicides. Obviously, the most big complication in life, right? We don't have life. 58% of these gun owners tend to be in the rural areas, and the suburban and urban areas, you can see the numbers there. When we look at, from a public health perspective, we do know that, and I'll speak to that in a bit, is that gun-related non-fatal injuries, obviously when you're dead, you end up in the morgue, but when you come into the hospital, it puts a lot of burden on our hospital systems. And when you look at the cause for the non-fatal injuries, you'll see that unintentional injuries from firearms as well as assaults are the highest. And the reason why this is important is that these things are modifiable, they're preventable, and that is why we need to look at them and focus on it. So by and large, as you must have heard in your earlier grand rounds, firearms are related more to suicide than homicide. And the most high rates of homicides are in the African-American population, and white males tend to have the highest rate of suicide. So we've all been taught that in our public health lectures and so on and so forth. But there's a large swath of the US population which somehow or the other comes in contact with this type of injury or death. If you look at the CDC data, it is very troubling to find that this is the only element which appears to have in the wrong direction, that is suicide, in the 10 to 24 age group. And people are struggling with trying to find out the reasons and stop this from going forward, because smoking, use of substances, all of those are in the downtrend, whereas this statistic seems to be going up. If you look at homicide, on the other hand, it tends to be decreasing, which is a really good news. And we need to sort of keep that from changing direction. So there are a variety of different reasons. And if you look at how children respond to some of these events in their lives, there is a tremendous increase in the fear that young people have about worrying that a shooting could happen in their school. And we've seen a whole bunch of school shootings recently. They do garner a great deal of attention. They're not that common. However, it is a high need. And we do know that if you look at the history of shootings, the first one was recorded in 1764, even before the United States came into being. The 1800s, 1900s, sporadic shooting here and there. But then we began to see the numbers climb in 1970. You have the Columbine shooting, you had the Virginia Tech, and then the Sandy Hook in your backwoods, and as well as the most recent one in Florida with the Parkland shooting. And kids have become more aware of all of these things. And it is a part and parcel of daily life to think what's going to happen. We certainly saw that this past week. It can be sensationalized, but this is sort of the bottom line. U.S. is second in the world after Brazil for unadjusted firearm fatalities, and that's kind of sad. And we are in the top 20 in the world if you look at the adjusted rate per 100,000 population. We are twice as common to have firearm-related deaths in comparison to Europe. And when you look at non-firearm-related violence, we are in the bottom. So clearly, firearms have catapulted us into a place where we probably don't want to be. So this issue comes up all the time about firearms, and these are the folks who end up saying that, oh, this is because people are crazy, and therefore there's something wrong with them mentally, and therefore they engage in this. However, the science and the literature doesn't support it, and that we know that 96% of the violence occurs due to reasons other than serious mental illness. Only 3% of this pie, the sliver, is attributable to mental illness. And even within mental illness, it is psychosis, schizophrenia, along with a significant substance abuse as a risk factor. And so that is what is seen as the contribution of mental illness to the overall violence. So what are the risk factors for gun-related violence? Certainly young males who have had a history of violence, have been exposed to violence, are substance abusers, as I said, and tend to be fairly impulsive, because we do understand that suicide particularly is something which often occurs secondary to impulsivity. It's a reflex thing, and it is not premeditated. And sometimes impulsive anger also with people who have difficulty with their temper control, and translates into domestic violence and intimate partner violence. Poverty can sometimes breed, is a risk factor, and when a child has been traumatized. So the role of ACEs in the person's life. And having said that, I certainly see this in my population, where you see a myriad of reactions to homicides and suicides in the kids who come into my clinic. And it can vary. And so it's up to you how you want to look at the genesis of what occurred. But these kids can be aggressive, they can be anxious, they can be depressed. They have what is called anxiety avoidance, which is specific for this thing. And you can have children go into substance abusing situations, and a variety of different things. So it can take on, just like trauma, so many different phases. And not everyone ends up having mental health problems. And that allows us to look at what are the elements of resilience which prevent these outcomes in some populations versus the others. So we certainly know that suicide and guns are very, very intimately connected. And the most important thing to understand is that this is an easily modifiable factor, meaning that if we were to put distance between guns and a person contemplating suicide, we can reduce mortality enormously. It's important to understand what are the warning signs and what are risk factors. Warning signs are things like giving away your possessions, being immensely depressed, using substance, talking about suicide. But risk factors are those which we know from some of the things that we have talked about, including access to lethal means in people who have a predilection for hurting themselves or hurting someone else. And these are easily modifiable. So you've got to sort of keep that in mind. Access to a gun in the home increases the odds of suicide more than threefold. And so it's not that you shouldn't own a gun, but if you have someone who is at risk, you certainly want to sit up and pay attention. I've had situations where I'm asking about this history from in a child who is profoundly depressed and is talking about suicide. And the parents say, yes, we have guns, but they are locked. And the child turned to me and said, they're not locked. I know where the ammunition is. And it was the parents just kind of sort of stared at him. But that's the degree of sometimes the need for education about these things. And they can prevent really bad stuff. So when you look at how people end up killing themselves, 10% of suicide attempts with non-firearms are fatal. So a very small proportion of any attempt. And in fact, that as you, the retry is less in these, but 90% of suicide attempts with a firearm are fatal. So it's not something to be sneezed at. It's a very, very important concept to grasp, that you are in real harm's way. So 9 out of 10 suicide attempts using firearms result in death, and means substitution is uncommon. So if someone is away, that lethal means they're not going to go and do something else. And 9 in 10 attempt survivors do not go on to die by suicide. 70% never attempt again. And this kind of sort of, this is more to do with the statistics regarding firearms. And the point this slide is making is that if you are able to prevent that from happening, you are in a much better place by putting time and space between at-risk individuals and firearms. Remember, we talked about the notion of impulsivity, and oftentimes these things occur just like in a minute. So this is very important to have in mind as you think of prevention and a public health approach. So these are some of the examples from my own clinical experience, which are very telling. You know, and you all probably recognize that from your practices, those who work in child mental health. 7-year-old, regular follow-up for ADHD, and is very withdrawn, visibly shaking, has just attended the funeral of a 5-year-old cousin who accidentally shot himself. This kid had picked up a gun, which belonged to his uncle, who had left it on the bed, was playing with it, and off the gun goes, and this kid dies. And this kid, who's my patient, he's very numb, but he is extremely anxious, will not look at me in the eye. And I can see the reverberations of this are going to continue to plague him for years on end, because he just can't get rid of that image. 10-year-old kid who has a situation where she has been really witness to domestic violence and neglect, and secondary to the trauma, ends up getting very, very depressed, goes to spend an evening at a friend's home. And as she's doing that, where she's hiding the closet, she finds a gun lying there. And she picks up, because she's so depressed, she picks up the gun and pulls the trigger. And the gun misfired. And the woman, the mother of the friend that she had gone to live with, further probed this. And eventually the custody was changed because a significant amount of, but anyway, this kid would end up dead, something not being, that if that gun had not misfired. So we see a lot of these types of experiences of young people who are exposed to a huge bunch of trauma in relationship to homicides in their neighborhoods, community violence, and we rarely ever ask for that within a medical setting. I hope that child psychiatrists ask this always, but other arenas of medicine, you are seeing these kids coming in, but we never ask, just like with sex trafficking or child trafficking. One kid that I saw came to me 6 months after this event, where a bullet grazed her scalp while she was sleeping at her grandma's home at 5 a.m. The bullet was not meant for that home. It was an accidental thing, but she ended up having multiple surgeries and has now full-fledged, PTSD, sleep, has lost weight, aggressive outbursts, and does not want to talk about that issue at all. So we have a ubiquitous presence of this within certain sections of our communities, and then secondary to other problems, firearms remain a major public health hazard. Our paradigm of how we approach this as medical professionals is that someone comes into an ED, they're resuscitated, and either they die and they go into the morgue, or they're rehabilitated till the next event comes around and you see the same people appear on your doorstep. But we forget that the secondary problems as a result of that shooting are immense. There's the friend of the person who's been shot, the parent, the witness. I always think when I look at people dying, that so much of libidinal energy, so much of investment has gone into this body, and in a fraction of a second, it's totally gone. So it has an impact upon so many people. In fact, there is the vicarious traumatization of people like us who watch this again and again, day in and day out in certain specialties like trauma surgery or, say, the emergency room, or people like me who are watching these young people get very anxious, depressed, and so on and so forth, and you stand there helplessly, not knowing what to do. In fact, the data suggests that for every one person who gets killed, 137 people in their lives are impacted in some way. So it has a great public health hazard and cannot be also the copycat nature of many of these things, like suicides, for example, or even homicides. And there have been a lot of work done on the mirroring effect of violence and as a risk factor. So it has a major impact upon society as a whole. So this is just sort of pulling all of that together, and you can see how many people are impacted by this. So opportunities for us from a public health aspect is to really stop the risk factors from being expressed, and then stopping the risk factors from escalating by intervention so that the shooting never occurs. And so that's the framework that I like people to think in terms of, and that really remove the notion, the polarizing notion of getting into the Second Amendment, but talking about how you want people to be safe. And I think even those who own guns or are gun shop owners or policymakers would all agree that is a common goal behind which we can unite. Violence prevention can take the shape of, wherever you're working as a geriatrician, or you can as an adult person, or even as a child. It really kind of sets the stage for some people to continue to experience violence, whichever. And these different types of violence all carry the same common risk factors and protective factors. And so the good news with this is that you need to sort of wrap your arms around looking at those commonalities and address them in a public health forum. You probably reduce the overall expression of violence in the community. So principles of public health, a quick rundown on this, if you recall, is that when we think of a public health model, we think we first have to define what the problem is. And we've talked a little bit about that, and I'll go over it again. And then look at risk and protective factors. And basically, in a public health paradigm, you want to reduce the risk and you want to increase the protective factors. Then you find out what are the evidence-based interventions which actually work, because some things may sound face valid, and they may, on an abstract level, feel good, but they're not effective. And so you really have to put into place evidence-based interventions which have known to work, and then as you put them into place, have the capacity to look at outcome after implementation. If the outcome is not where you want to, you refine the model again, and you continue to go through this cycle till you have reached a point where it works. And there are many, many examples of these as you look at motor vehicle accidents reduced by use, reduction of lung cancer by reducing smoking, which when I went to residency, I would come home reeking of smoke from top to bottom, and there was nothing I could do about it, or at least I felt that way, till this became a public health issue. Similarly, there are things which can be done. They're in people's rights. So, for example, you can own an automobile, but you have to go by certain rules. You have to have a license. You have to wear the seatbelt. It doesn't curtail people's freedom to drive, but it puts a scaffolding and a parameter which is going to move you in the right direction. So for anything that you're doing, your work in medicine, this is a good paradigm to have, because it really looks at system reform as you go along. And essentially, when you're looking at how we translate, we take the research which we have, the basic science, and in the meantime, you're also very aware of the political fallout from stuff, and try to understand analytically where you need to put your work in and power in, besides advocacy. Strategic engagement in really getting others like you have a consensus, get stakeholder participation, and really not only do a grassroots level organizing, but top down too. So in Virginia, we really try to get we had a first summit on getting physicians involved, this stuff which never has been sort of in the forefront. You guys probably way ahead of that because Sandy Hook and so on and so forth. But then looking at a state level directorship where someone can take on this issue and begin to talk to senators and policymakers. And then really kind of getting public education, because the biggest thing in the US is that if the public is educated and well educated, you're going to get things done. If they're not and have no idea, and it's a polarizing issue and you don't do it well, your argument is dead right in there. And then the implementation of the policy. So what is the problem? We kind of know, I've already talked about it. Firearms is the method used in half of all suicide deaths. More than half of female intimate partner homicides are committed by a firearm. And this is really a very sad statistic, and I'll be going as a slide devoted just to that. And nearly 3 out of 4 homicides are committed by a firearm. Nearly 100 children and youth die each year due to unintentional firearm injuries. And this is the amount of sort of the economic toll that this takes on the health systems. Certainly when people tell us stay in your lane, we are in a lane, because each time someone gets killed, they come or are injured, they come to the emergency room or wherever, and it starts not only patching them up and the time that they spend on our inpatient floors, but it also is the counseling that goes along, and it also is sort of the prevention that is for their families, etc. So it's not a single incident. It takes with it a significant toll. Okay, what happened here? Okay, so who are at risk? Those individuals who have a history of suicide attempt, history of assault by a peer, and use guns for protection. I see that a lot in my juvenile justice population. And they're already in there, so they very freely share what are the reasons why they have their guns. And in this particular population, who are in the juvenile justice setting, there's a significant amount for the look of the thing, for protection. These kids have a very poor, short sense of the future, meaning a foreshortened future, and they don't really care and start getting into guns because it's a highly lucrative trade. Those experiencing partner violence, history of alcohol and substance abuse. So we kind of sort of get a sense of what are the things which put people at risk. Identifying these risk and protective factors, and particularly violence, but also looking at a larger systems level in certain communities and certain populations as to what are the sentinel reasons why people move in the direction of gun acquisition and use. And oftentimes when you look at these populations, there's a lack of opportunities. They can't get employment. They have modeled for them behaviors which kind of condone some of these. They have very little structural things in place which prevent the violence. And poverty is one of the things which exaggerates it. Not that all people who live in poverty end up having trouble, because some of them have those resilience, those elements which we need to study more and bolster. But communities really need to be scaffolded, because that's the best primary prevention that you can engage in to stop people getting into harm's way. So interventions which target behavioral risk factors for firearm violence, remember in that square where you have to look at what are evidence-based interventions. So we do know that the ERPO laws, domestic violence prohibition, and the extreme risk laws are really an important intervention, which is now showing promise in reducing deaths from firearms. Interventions which interrupt cycles of violence and connect the highest risk individuals to services in the community. So this is a point well taken, that when we do see violence directed towards women, it's connected to intimate partner a former intimate partner, 4.5 million women in the US who have been threatened with a gun, and nearly 1 million women who have been shot at is in this scenario. And half of intimate partner homicides are committed with guns. I don't know how many stories you all have. We all kind of see this in front of us, and it's really sad. A woman is 5 times more likely to be murdered when her partner has threatened her with a gun in the past. And so anytime these events occur, this person is at high risk, and the gun needs to be confiscated and removed so that they don't. It's a factor that we know so well. So extreme risk protection orders, which is really seen through some of these post-hoc analysis in Indiana as well as Connecticut, both have shown that for every 10 to 11 guns which are removed under the ERPO, 1 life has been saved. It allows law enforcement officials, often at the request of a family member, to petition a judge to temporarily remove firearms from a person behaving dangerously before tragedy occurs. So you don't have to, if there's a suspicion, you can do that. The person has about 2 weeks to actually put forward their case to counter this argument. And if they're able to, then they can leave. Otherwise, 6 months is a period of the ERPO. There are 20 states, along with the District of Columbia, where the ERPO laws have been passed. And I'm glad to report that Virginia is one of the newest member of this coalition. And essentially, this has shown that both in Connecticut and in Indiana, that we now have data to show that lives get saved each time the ERPO is put into place. So what about what do we know? Because as we say in the public health model, you need the evidence, you need the research, you need to, and I spoke to it in my first slide in talking about how research into gun violence has been stymied by some of the things that have occurred at a federal level. In fact, the NIH in 2009 published a very strong case for talking about how guns are related to homicide deaths and suicide deaths. And the next thing was that the Congress enacted a law which prevented any money for gun research to go to any federal agency like the NIH. And so that was stopped. So this is where we sit in the projected amount of dollars that go into research. You can see where gun violence is. And in fact, I don't have that slide, but the contribution of dollars where it comes from for the amount of research which has been done, there are about 8 research places where this is conducted, come from charitable organizations. So it's not coming from the federal government. It is not coming from the CDC. And so it's coming primarily from these charitable organizations. And the educational fund for stopping gun violence is a very strong one. In fact, I borrowed heavily from their work, and I've presented many times with Josh Horowitz from the Bloomberg School of Public Health at Johns Hopkins, which does a bunch of this work. So think of gun violence in this form, where we look at it from a socio-ecological model. I really believe in sort of the systems that there is not one fact answer to stuff, but you can begin to focus on each of these sort of areas and see how we can reduce this. This is work that was done by Olchen and Josh Horowitz, the person that I was speaking about. And so if you look at it from the bottom up, when we look at an individual level, we can do as individuals is that if we do own a gun, how do we engage in safer storage, appropriate safety locks, and kind of knowing where the risk sits. And if there is risk, how do we kind of get that gun away from the at-risk person? From relationship aspect, family and friends holding on to firearms while the risk exists so that you can get it back later, but you are, again, putting distance between this lethal arm. And also, lethal means safety counseling. Knowing how to do that in an appropriate fashion, appropriate in any situation where you feel you can intervene, because this is just education and has nothing to do with medicine per se. community gun shop projects, going to gun shop owners or other people who are engaged in this, and really coming up with we are on the same page type of an idea, that we all want people to be safe. And this is not about, eating your lunch or stopping your business, but really for us to work together to really come up with a project wherein we can be on the same page to stop these guns to be in the wrong hands. And on a societal level, extreme risk clause, which is a policy issue. Licensing, we've talked about the background checks. Right now, HB 8 at the federal level is really facing a lot of, as you know, a lot of flack. But nevertheless, bringing these things up again about stopping the loopholes in gun purchasing, mandatory waiting periods. These are just common sense laws which are not kind of getting in the way. But the polarizing sort of the other side of the view is that this is a slip slope and we don't want to go there. So it becomes very important how to finesse that argument and get people to this notion of how do you keep people safe. And I think that will get us out of this polarizing sort of notion, although I doubt it. As in our role as healthcare providers, we very infrequently ask about a person's risk within the community about violence. And provider, this sort of just shows what a provider should ask, as parents say, and what the provider does ask. So smoker in the household, but we rarely ask about community violence. We become much better at screening for violence within the home, and are you scared, and all of those kinds of things, which is a step in the right direction. But again, this needs to be right up there in everyone's mind as we interface with the community. As an individual clinician, so now I'm kind of getting into what you can do. So the biggest thing that one can do is to talk to patients who are at risk of firearm injury, or either depressed or suicidal, victims of domestic violence, victims of assault, or parents. Whenever you see that there's a high risk, to then begin to keeping this sort of notion in your mind that 1 in 3 homes in the United States has a gun, and 3 in 4 children who are living within those homes have knowledge about the ammunition and the guns, the example I gave. And 80% of the deaths related to firearms of children occur within a home. There are 17,000 deaths of children due to firearm injuries every year. And this is the number 2 leading cause for death in children and youth. And so these are sort of important things to keep in mind as you ask these questions. This really, the Florida Dr. Okinwa versus, Ms. Ullman, who was the patient, led to the gag laws. But empathetic interviews really involve you getting into this way of asking things. What do you think about storing? So if you have a person who's at risk and you're really worried about them, rather than being sort of in their face, questions such as, what do you think about storing your guns off-site until the situation improves? Have you thought about keeping your kids, how to keep your kids safe around your guns? Let's talk about how to lower the risk of your boyfriend hurting or killing you. I'm not saying you have to give up or dispose of your gun. We're just talking about safety. So these are some of the things that it's almost like talking about sex or alcohol use, These are questions that should become part of your repertoire as you are talking with patients. So certainly when we have a fear about acute risk, this is an emergency and you know what to do in this case. Send them to the emergency room. Talk about safe storage. Get the person away from the gun and so on and so forth. When a person is in all of these situations, I think the biggest thing is to counsel to first of all, focus on risk reduction by removing them away from. And this is what we do. We do TDOs, we do ECOs, and get people into psychiatric facility or have them sit in ED. But then also, this is a great time to talk about safer storage for parents and to counsel folks on involving parents in this discussion. Lethal means safety counseling is a very important concept. And in this, you are really trying to mitigate the risk for at-risk people by temporarily reducing access to guns until the risk subsides. And this is very effective. Evidence shows that anytime a physician or a health provider brings this up and has a long discussion about it, it reduces the person's lackadaisical approach towards storage and keeping their guns in a place available to the person at risk. And the research does show that there's a big difference in the behavior of people as far as firearm storage practices with the lethal means safety counseling. So the very easy ways to kind of remember are the 5 L's. So if you do know that someone has a firearm in the home, you want to ask, is it locked? L, is it loaded? Are there little children around the guns? Are these people feeling low at any point? So you're kind of sort of exploring the depression, etc. And last is that do people, are they, the term is used as a learned person who sort of has the gun, the firearm, the owner, are they educated about it? So these are some of the lethal means counseling, which is a conversation. Once you have that, then you kind of improve the chances that the person is going to store their guns safely. Basically, we are trying to temporarily reduce access to firearms for individuals at risk for suicide. And this is the most effective thing that you can do to save their lives. There are resources. There's a 2-hour course on counseling on access to lethal means at the Suicide Prevention Resource Center. So these are some things that are like right on your fingertips to provide as a resource for folks. And so these are some things that you can do and you can be thinking about. Safer storage, safety locks on guns, lethal means safety counseling. Each time you talk to a person, you can kind of explore those and help explain what's going on. On a community level, getting into sort of connecting with gun shop projects. I know we are all very, very busy, but if this is something you'd like to do, this would be a terrific project to get into. And certainly on a policy level, things like RPOs and so on and so forth. These are some of the things that are happening in Virginia. I don't need to go into it with you because every state has got a different way of looking at it. But we are feeling like we are kind of getting better at some of these, and some of it is sort of the mindset changing in Virginia. However, the one program that has been shown to have evidence base is the hospital-based violence intervention program. And I'm proud to say that VCU has one of those. Basically, these are identified gunshot injury patients who are at high risk for re-victimization, which rates near 50%. So this was done by one of our trauma surgeons who was just fed up of seeing these people circling back again and again. And he developed this program, which is now being funded by a governor at $2.45 million to build this up at 7 hospitals in the state. It's essentially identifying patients at risk for re-victimization and using the injury as a teachable moment and providing culturally competent case management. So they're connected to a case manager who then follows them. And basically, we are trying to sort of get at the root causes of the violence and preventing these things from happening. So this is one of those evidence-based programs, which is something to be looked at in an acute setting of hospitals. These are some of the things that have been helpful in certain areas of the country to reduce some of these. And then I think I just have about 2-3 minutes to go over policy intervention before I stop. So this is at a larger level. So I've spoken about some of the individual level things that you could get involved with, not everything, but something that you could possibly do. And then from a policy intervention, there are a bunch of things that we have in Virginia, which we are looking at. We're not very successful with everything, but the RPOs definitely passed. We are now banning the presence of, we've just passed the bill for banning the presence of firearms, near polling stations, for example, in certain, around churches, and there are several other places that they have identified. So the focus has been presence of firearms in certain community-related places. We're looking at background checks, and certainly Tim Kaine has been a big person who has been a champion. You have to find champions who really look at this. So getting your voice of authority wherever and whenever you can. And I think that in response to, be in your lane, I think we have made a case for we are in a lane. Because when people get injured or there's fatality, it is the office of the medical examiner who gets involved, and all of the money that goes into sustaining that, as well as what happens in the ED and all of the things that I've talked about. We certainly are in a lane because it is an issue that we want to prevent from the perspective of mortality and morbidity that goes on. Writing op-eds and letters to the editor wherever it's, and not to make it too political, but to again focus on the safety aspect of it. Contributing to professional newsletters, speaking at professional conferences. So for example, one of the things that we strategically did about 2 years ago is how do we do grand rounds at different Virginia medical schools so that young people can hear this and really become advocates for stopping this highly preventable and modifiable problem in the areas that they live in. Offer up learning opportunities at your place of employment, lunch and learn, grand rounds, leading a discussion group at your workplace. Social media advocacy. Again, from a physician standpoint, so you can, as JoQ Public and someone just as a person who belongs to the community, you can do whatever you feel like. But as a physician, I think as a public health person, you really need to get out of polarizing impact of it, really talk about safety as a major sort of issue. American Academy of Pediatrics has done a really good job in putting their muscle behind many of these things. So find out who are the powers within your state and who you would like to align yourself with if this is something that concerns you. So advocacy arm of your professional group. These are all of the different arenas where people are finally sitting up and saying. One of the problems with most organizations can be that they feel that as they're lobbying for other resolutions at a state or federal level, that as soon as they talk about gun-related issues, that somehow their message will be obfuscated and all of those things will be pushed to the side. So there's a big fear in organizations that they don't want to get behind this highly polarizing issue. And we have to just evolve as a community. So I think I've been sort of kind of successful at finishing in time, but here are your text code for your CME credits. And at this point, I'll just leave this on the screen for a bit, and I'm open for questions. Can you hear me?
Wonderful presentation, very educational and thought-provoking. I really like the social ecological model that you talked about. And also thank you for highlighting and bringing our attention to the victims and survivors of, gun violence, and also the vicarious impact it has on the healthcare providers. I'm going to monitor the chat box. So for folks who are still here, please let us know about your question. I have one question from one of the participants who's asking that for high schools, would you recommend metal detectors to prevent guns from entering the school premises?
So this is a very controversial, this is like that same stuff about, the active shooter training for kids and, the metal detectors and so on and so forth. And this is, again, one of those polarizing debates because I don't think we have evidence to say that that is going to deter people. I feel like my personal sort of viewpoint about this is to really look at school climate and really approach it from that standpoint. Police personnel and can I sharing the screens that I can okay, let me see. Oh, here we are. Okay. Yeah. Is that okay?
Yep.
Okay. Yeah. So yes. So I think that is every I guess the jury is out on that type of a thing as to using of a metal detector. The basic thing is how do you get your schools to be safe? And I think that educational institutions are, because there has been this highly publicized media type of thing on schools, and the onus is on them how to keep the children safe. I can see how the metal detector issue and really the hardening of basically the structure around the school, but really does that get at the central issue of why people end up, bursting into a school and victimizing kids? To me, it's more about really having the pulse on the school climate and those kinds of issues. So as a health professional, that is what I would kind of say, is that school systems, and I don't know how an entire school community, entire school board would kind of act upon it, because it's a more, how should I say, abstract and a more, it doesn't allow, when you talk about school climate, it doesn't allow people to see something specific being done. And so our general tendency as a human being is, okay, now we have put these metal detectors in, somehow we are safer. And we all know that that is not the case. So to me, it always is get to the fundamental level of why this is happening and really be into it. And certainly in the community, we can't really stop disenfranchised people from being so upset. And I would say that our effort in recognizing those elements within a society, which we have not full control over at all. But why is the person coming back is as a former student. So goes back again to sort of the notion of who you graduate, what kind of a school climate do you have on multiple levels, on a primary, secondary, and tertiary level? What are you doing? And you all really have done so much of work around those issues, because if you have that in place, then you're not doing these, to me, cosmetic changes within the structure of a school. And again, that is something that most law enforcement officers and others, in fact, I have to share this, that when I was, when President Obama was in power, now President Biden came down to BCU, and I actually had a conversation about him just on this issue. He brought up this thing of what should we do to harden the schools, no, not harden the school, to prevent violence, because I don't think he's really leaning more in direction. But it was interesting that there was a complete polarization between the health professional people versus the chief of police and how they viewed the thing. So there was a diametrically different view of it. And so we come at it from a very different vantage point. To me, I look at the fundamental underlying reasons why people end up committing these things and how to reduce that risk, rather than looking at what do you do with, because if someone is really determined, they're going to find some other reason. They'll probably end up in the mall, or they'll end up somewhere else, not the school. Yeah. So
thank you for that.
Does that make sense?
Yeah. Thank you. I think I have two more folks. Dr. Farrand has a comment, and then Dr. Schwartz has a question. Is it possible to open their mics? So Jennifer Farrand and then Dr. Schwartz. Dr. Farrand.
All right. Rounds. It's at 1 today. We got an email yesterday.
Hello?
Yes. All right. So, Dr. Farrand, I don't know if you want to put your comment. I have a question from Dr. Schwartz that I'm going to read it. So the data that only 4% of serious violence is committed by individuals who are mentally ill does not address the fact that among the most visible mass shooting, a much higher percentage seems to be committed by the individual who are ill. Please comment.
So I think when you look at these people, there are a variety of other risk factors. I mean, there definitely there's something wrong with them, right? But as you look at the prevalence of violence and look at how firearm injuries occur and so on and so forth, they eventually kind of end up with these highly sensationalized events in which mental health is one factor. But in the larger population, when you kind of look at firearm injury and who are the people who are committing these, which don't really get to that level, mental illness is really 3% or 4% based upon the scientific studies which have looked at it. So we're not kind of getting at the other firearm-related shootings, but perhaps at the larger shootings which do occur. That you do see that. And generally in those, there is either psychosis, and particularly which has been complicated by substance abuse.
Thank you. Dr. Farand, and people are also asking if it's okay, Dr. Sood, if we can share the slides with them.
Yes, absolutely. Absolutely. Please use them to give your own talks and so on and so forth, because the more we really get the data out and educate people, I'm hoping that it'll lead to a better informed health professions, because normally we don't consider ourselves as part of this discussion.
Thank you. Any other questions? Dr. Farand had a comment, but it seems like we cannot turn her individual mic on.
Can she type it in the chat?
No. Oh, okay. So, yes, she did. She wanted to say that our Zero Suicide Initiative has taught us a lot about these issues, and we have many opportunities at several levels. First, we have opportunity as a state to collaborate with the gun lobby and gun shop owners. We're working on it, and also wanted to let people know that as a follow-up to this meeting, Dr. Farand will make sure everyone has access to the CALM training and the EPIC SMART phrase that, we can document it and that too.
Okay.
Thank you, Dr.
Fantastic. Wow. That's really nice to know. That's great.
Yeah.
Mm-hmm. Yeah, because I think that even as a clinician, it is really good to know that the nurses are asking always screening for domestic violence. They're asking about, do you feel safe? And I know sometimes it seems very pedantic, but I think it just raises everyone's awareness that these are problems, including the whole child trafficking and the sex trafficking stuff, which we never paid attention to. But now ED docs are doing more of that. These are people at great risk, and we just don't give it due diligence because it's not in our radar. So the more we increase that awareness, the better we're going to be with this.
Yeah, absolutely. Well, any other questions that anyone has? Well, I guess thank you so much, Dr. Sood, for your time. This was wonderful.
Wonderful. I'm so happy that I was able to finish in time. Rarely able to do that. So.